Okay. Hi, good evening, everyone. Welcome to this IARS virtual education session titled Unveiling the Past, Embracing the Present, and Shaping the Future of Transplant Anesthesia, which is co-sponsored by the Society for the Advancement of Transplant Anesthesia, SATA, which I'm the current president of. And this program has not received any commercial support. And we have to go through a few slides before starting the presentation. The first one, if you missed the 2025 annual meeting back in Hawaii, sorry for you because it was great, especially the weather. Well, on-demand recording are available for purchase, and registered attendee have complimentary access, and you can use the address, web address that you can see at the bottom of these slides. There's going to be the 2026 annual meeting, IARS and Sakai meeting is going to be in Montreal, in Canada, between May 1st and May 3rd at Fairmount Queen Elizabeth Hospital. So just look out for enrollment. Late free abstract submission will be opening soon, and you can present your research at the 2026 annual meeting presented by the IARS and Sakai, as I mentioned before, on May 1st and 3rd in Montreal, Canada. The late-breaking abstract category allowed the submission of a truly late abstract, high-impact scientific research for which results were not available at the time of the general abstract submission deadline. Late-breaking abstracts should present data that are high-impact, groundbreaking, innovative, and newsworthy. Medically challenging cases are not accepted for late-breaking submission. For more information, visit the website over here on the slide. Just some other housekeeping. Upcoming webinars are going to be Breathing Easy from Difficult Airway to Every Airway, Improving Safety of Airway Management in Pediatric Anesthesia, scheduled for January 13, 2026, 4 p.m. Eastern Standard Time, followed by Beyond Awareness, Practical Approaches to Overcoming Barriers in Physician Mental Health, which is going to be on February 10, 2026 at 4 p.m. Eastern Standard Time still. Use the Q&A button if you have any question during this session, and all the questions are going to be answered at the end of the presentation. Now, I'm not Dr. Geber Wagner, which unfortunately today cannot moderate this session. Because I had a little procedure done. So I'm the first speaker. My name is Lorenzo Marchi. I'm a director of Transplant Anesthesia, MedStar-Georgetown University Hospital in Washington, D.C., and professor of clinical anesthesia at Georgetown University. And I'm going to stop sharing this screen and start sharing my presentation. Give me a second. There you go. Sure. Okay. Good evening. As I mentioned, Lorenzo Marchi is my name, and tonight I've been tasked to talk to you about the rapidly shifting world of transplantation and how technology like machine perfusion or the DCD organs and the new organ allocation system has affected us as anesthesiologists. I don't have any disclosure to make related to the procedure, to this presentation, and I just want to start with this image. That is representing Ouroboros, or a snake that eats its own tail, which using in old ancient society to represent the circle of life, or the fact that events are connected to each other, consequence to each other. In particular, I want to focus on these 3 dates, which we're going to see why they are related to the talk that we're having tonight. So this is a graph that I plotted myself using data from SRTR regarding the total number of liver transplants in the United States. And you can see that, there's a constant, steady increase throughout the past 10 years, but something happened in 2022 that raised significantly the number of transplants compared to the previous years. And if you plot the number of DCD liver donor in the United States, you can notice that more or less the same year, you have this upswing of the line or the curve, and in a significant fashion, I would say. But before talking about what happened in 2022, I want to just go back a couple of years, go back to 2020, particularly February 2020, which is where a new allocation system for liver transplant was put in place by UNOS. And the new allocation system moved from what we used to be a donation service areas or region in terms of allocation of the organ. So where center used to have priority on the local organs before being offered to neighbors regions. So from this region system, we switched to an acuity circle system in which the donor hospital was at the center of concentric circles of progressively increasing radius, 150 to 15,500 nautical mile, and the recipient were looked for was searched into this progressively increased circle, looking, of course, starting from the sickest of the sickest, status 1, and then going down to if there was any status between 40 or 37 of males, and going down progressively. Now, just to be clear, I didn't know actually myself. 1 nautical mile is basically a little bit more than 1 mile, and so 500 nautical miles, it's almost 600 miles. And for who is used to metric system, is almost a radius of 1,000 kilometers. And so how this new system can impact, how can we explain the increase in DCD that we have in 2022 when a few years before we had a system put in place that allow us to go for 1,000 miles to retrieve an organ. Now, everybody knows that when you talk about DCD, time is money, and in the sense that the surgeon already is going to have to deal with the functional working ischemia time of the organ and then retrieve as fast as possible with super rapid technique in order to bring back to the recipient hospital the organ. And of course, when you need to go 1,000 miles away, I mean, Mr. Scott cannot beam up our surgeon and bring him over there. So something else, has to happen in order for them to be so far and retrieve organ. And to discuss that, I want to move back even more in the past and go back to 2016, which is more or less 10 years ago, where a new hope started for heart surgeons. And in particular, when Queen Elizabeth Hospital in Birmingham, which is probably the biggest transplant center in the United Kingdom, a group of scientists develop a machine in which you can put in the organ, the liver in this case, and perfuse it with oxygenated blood, and at the same time look at different parameters like bioproduction or clearance, lactate clearance. So basically, the people in Birmingham develop a system for which you can easily harvest the organ, put it on the pump, load it on a ambulance, and then bring it to the recipient hospital, look at it, and then transplanted it, virtually abolishing the need of some cold storage like we normally used to do. And this is the first publication that they did in 2016, in which they literally resuscitated a liver that nobody wanted with this normothermic machine perfusion. And you can see at the bottom left corner, that's the curve of clearance of lactate. So lactate, after a couple of hours, start clearing, and then they stay stable to a normal level. So this liver was working after being technically really resuscitated. So, but why, this technology was developed 10 years ago? Why do we have to wait for 2022, where we see the use of DCD goes up? And the simple reason is that, as always happen, that's when the organ oximeter, which is the machine, the device developed in the UK, was finally FDA approved. And here you can see the most common, the one that we have available in the United States for normothermic machine perfusion, organ oximeter and transmedic. So this device, placing the organ in this device allow you to restore the metabolism of the organ, literally, like I said before, resuscitate the organ. At the same time, allow viability assessment. As I mentioned before, you can look at the clearance of lactate and see if the organ is working in that sense, if it's making biles, what's the blood flow and pressure. But most of all, allow to extend the preservation time to times that unheard before, to 12, 20 hours. And I'm pretty sure that some places went even beyond that. And that was the main reason why we had that upswing of the DCD line in 2022, as witnessed by this recent article in 2024 from Weasel, that shows that increase in utilization of DCD, and not only, but also more marginal graft because of the use of machine perfusion. And that's kind of reflect what has been the trend in the rest of the world, even on the other side of the pond with machine perfusion. And the other perk that comes with extending the preservation time so long for 2021, 20 hours, up to 20 hours semi-4, is also the fact that at this point we can control and make predictable the OR time. So basically we can transform what used to be a 2 a.m. fire drill into a 9 to 5 transplant. And so the new workflow that this technology has generated is, it's translated in an offer that comes the day before, and in harvest maybe during the night, organ that comes to the hospital get placed on the normothermic machine perfusion, and overnight receiving a viability test. The surgeon decide if he can use the organ or not, and then schedule easily in the morning the transplant. And so taking away that classic, in the middle of the night, start of the case and induction, and doing those cases, especially in the sickest patient during the day where a fully staffed OR and your colleagues around to help, and making everything in a certain sense safer. And to say that, I mean, when things are done during the day, as probably, in the mind of everybody, they are safer. But there is, as you can see, this article from 2010, which looking at potential complication after liver transplant, according to the operating time when the surgery starts, and the results were clearly that when you do surgery overnight, you have a longer duration of the surgery, you have an increased risk of death. And I mean, this is well known for, at this point, almost 15, 16 years, from 2020. Now, when I was a kid, there was this Mexican soap opera that my grandma used to watch, Anche Ricchi Piangono, that had a remake in the American, that The Rich Also Cry. But I would also argue that surgeons also sleep. So it's kind of, you can translate the results of those that article also to the fact that the surgeon needs to sleep. And more recent article remark again that after hours or nighttime surgery carry a higher burden of mortality, and not only operating during the night has a repercussion on the surgeon, increasing the risk of burnout and the risk of mistakes and problem. Now, I'm talking about surgeon. This is a talk about anesthesia, but I would argue that we really don't need a clinical trial to determine that that's beneficial also to anesthesiology. So the interesting part is that there's been a big change in the landscape in liver transplantation, driven by the allocation reform that increased the travel distance, but also the availability of organ to be retrieved. And this availability has been facilitated by the use of machine perfusion, that now is increased the number of organs in utilized, and that kind of reflect really what globally is happening for the DCD utilization. And not only the introduction of machine perfusion definitely allow and enable more control and planned daytime workflow. So going back to our wars, I mean, you can clearly see that what happened during those 3 years in terms of increase of DCD, and the new allocation system, and they're allowed to have more DCD, to reach more DCD, that they can be used because moved on pump, make everybody's life in a certain sense much better than what it was before. So like these three forces now interact and reshaped our transport workflow and the practice of our anesthesiologists. Thank you very much. And I swear this is a real text from one of my surgeons. And now I'm going to stop sharing. So I Now introducing the next speaker. This is Dr. Sakai, MD, PhD, MAH, MHA, and FASA. He's a tenured professor and chair of the Department of Anesthesiologist at the University of North Carolina at Chapel Hill in North Carolina. And today is going to talk about a lesson from 20 years of transplant anesthesia that every anesthesiologist should know. Thank you, Ted. It's all yours.
Thank you very much for your kind introduction. Hi, everybody. I just want to thank you for the IARS to provide the chance for the SATA members to present. I'm so honored to be the one of the presenter. So it happened to be I graduated from the residency in 2005, and so this is marked the 20th year. So I will just select my personal opinion regarding the 20 years of the review of the liver transplantation. I have some financial relationship with some of the company that's not include in this program. So as you know, end-stage liver disease is a systemic disease. As you can see that every single organ system get affected. But today, I would like to focus on the intraoperative cardiac arrest for the heart and also the relationship or the coagulation. So, coming in 15 minutes or so, I want to focus on the intracardiac arrest during the liver transplantation, when that happened, how that happened, what's the risk factors, what is the clinical presentation, possible etiology, and diagnostic predictors. And then so the major cause reveal that, and the result to you is that pulmonary thromboembolism. So switch the gear to the pulmonary thromboembolism again. How that incidence, what's the incidence, clinical presentation, outcome risk factors, diagnostic predictors, implication of the cryoprecipitate transfusion, and the occurrence of the PTE, and also the rescue measure of the TPA. So how often the heart stopped during the liver transplantation? We have the 7 academic centers in the United States gather together and then report the incidence and then 2021. And then so among the 5,296 cases which performed between 2000 and 2017, intracardiac arrest occurred in 3.7% of the cases, and then intraoperative mortality rate is high, 32%. And then so, 30 days and 1 year mortality, including the intraoperative death, include 44% and then 52%, which is significant. And then in the multi-variable generalized linear mixed model, and then intracardiac arrest was associated with posterior perfusion syndrome, and then high MELD score, and also high BMI, and then interestingly, living donors, and low BMI and reoperation, and also MELD score 32, 39. And then so intracardiac arrest during the liver transplantation revealed 3.7%. So does liver transplantation carry a higher risk in the intraoperative cardiac arrest compared to the other surgeries? Yes, indeed. And some of the report, Mayo Clinic in 2000 revealed that 4.3 cases per 10,000. And then following a study using the NACOR registry, which revealed 5.6 cases per 10,000 cases, which indicated that whenever you perform the liver transplantation, you have to anticipate, 100 times higher intraoperative cardiac arrest. And this is the high risk procedure. So and then more dissect into the what is the association and risk factors and also reason for it. I happen to work with the phenomenal researcher Takashi Matsaki, and then so at the UPMC, my prior institution for 8 years, between 2001 to 2009, reveal that incidence of the cardiac arrest in the 5.5 cases percent. Presentation is the asystole, 67%, and then the VFib and 32.4%. And then, as you can see on the left, there's no historical change in the incidence. So when the cardiac arrest occur, as you know, that liver transplantation divided into 3 phases: pre-unhepatic, unhepatic, and neohepatic. As you can see, it's clearly in a trend towards the intraoperative cardiac arrest occurred in the neohepatic phase. Especially, most vulnerable time is that within 5 minutes after the reperfusion of the new organ. So, it's clearly indicated that the sicker the patient preoperatively, the higher the risk for the intracardiac arrest. So we try very hard to review all the cases and then identify the possible etiology of the intracardiac arrest, which turned out to be the highest etiology is related to the post-reperfusion syndrome, 38.2%, followed by a pulmonary thromboembolism, 35.3%. Of note, during that study period, we have standardized the monitoring. All the patients received the TEE intraoperatively from the onset. So that is the reason that we reached that diagnosis relatively correctly. And then followed by hyperkalemia, uncontrolled bleeding, pulmonary edema, primary non-functioning graft, ICP during the fulminant hepatic failure, and unknown. It is important to see that uncontrolled bleeding is the only attributed to the intracardiac arrest in the 7.4% compared to the thromboembolism and the 35.3%. What is the outcome? Intraoperative death occurred in pulmonary thromboembolism, the 29.2%. Of course, hyperkalemic condition, 60% of the mortality. But given that incidence and also the higher number of the intraoperative death, pulmonary thromboembolism is of a concern. So pulmonary thromboembolism during the liver transplantation, you may see that liver transplantation, the hypocoagulable condition, why thromboembolism occurred during the liver transplantation. So when you get more detail about the exploration about the occurrence of the pulmonary thromboembolism during the adult liver transplantation, it resulted in the significant number. And then, as I mentioned, during that study period of the retrospective study at the UPMC, we inserted the TE for all the cases, as well as we placed the pulmonary Swan-Ganz catheter for every case. And then using those monitoring device, we determined that the diagnosis of the thromboembolism is both the hemodynamic changes, sudden onset of systemic hypotension with the elevated PAP or CVP, along with the TEE finding, the clot in the pulmonary artery trees or the chambers. What we found among the 495 liver transplantation cases for all the diseased liver, and then we found the 4.0%, 20 out of 492 has the incidence of PTE. Again, timing of the occurrence is the neo-hepatic phase, especially within the 5 minutes after the reperfusion. So outcome itself is significant. Operative mortality is 30%. PTE associated with the intracardiac arrest, 75% of the cases. And the 6 days mortality reached the 45% when you see the pulmonary thromboembolism during the liver transplantation. But I would like to get the attention to the decay of that survival curve, especially on the left. And then so you can see that significant difference between the non-PTE group versus PTE group, which is quite reasonable things to see. However, this survival curve indicated that if you can save the patient from the death intraoperatively after the PTE, the survival itself is along with the same decay with the known PT group. So the how to save the patient from the PTE, and then along with the intracardiac arrest is quite important. Clinical characteristics indicate that PT associated with the cardiac arrest, and then also the flat TEG thromboelastography especially within the 3 minutes, at the 5 minutes after the reperfusion phase, and also the TEG lysis was pronounced. So, which indicated that PTE associated with the systemic arterial hypotension, along with the flat TEG at 5 minutes after the reperfusion or all time throughout the liver transplantation. So this is quite reasonable because when you think about the thrombosis in the triangle, and then abnormal blood flow, and then the hypercoagulability in the face of the endothelial injury caused the thrombosis. So what is the hypercoagulability during the liver transplant? This is the slide, idea slide, given that Dr. Yugu Kane, who is the president, in the past president of the IOTS. And then so he indicated that there's a dynamite. And then so without the inflammatory response, the matches on the fire, there's no reaction. However, even though the coagulation factors is scarce, if you have the significant inflammatory response and you have a major thrombosis. So this is the interesting concept. And then when you think about it, during the liver transplantation, quite often disseminated intravascular coagulation happen. So this is quite noticeable for the retrospective study reported from Miami group using the 48 adult visceral transplantation. The incidence of the ICT and then intracardiac clot thrombosis and the PE occurred of 25% of the multivisceral transplant, associated with the 50% of the mortality. And then preoperative portal vein thrombosis, as well as TEG, a DIC pattern statistically associated with the occurrence. So they categorize the pattern of the DIC based on the TEG. As you can see, literally, flat line is considered to be the DIC type C. So again, and then so inflammatory response is probably the DIC type of the coagulation abnormality. So what is the kind of impact cryoprecipitate in this story? There's a very significant, important study published from UCLA group, Christine Nguyen-Buckley, and also Dr. Victor Gia's group. So they reviewed the 2,330 patients and then see that historical change of the occurrence of the thromboembolic complications. And then they identified that after the application of the Rotem for the Rotem guided coagulation pathway implemented in the 2015, they saw that a significant increase of the usage of the cryoprecipitate, and then actually 3 times more average cryoprecipitate used for the liver transplantation. And so they saw that reduction of the FFP while the increase of the cryoprecipitate before and then after the Rotem application. And then so they can see the significant increase of the intraoperative intracardiac thrombosis as well as PE and also hepatic artery thrombosis and a stroke when they compare the period 1 before the Rotem and then period 2, the post-Rotem. So they also identified the dose-related curve. The more you use the cryoprecipitate, there's more incidence of the major thromboembolic complications. And then they identified the cryoprecipitate as the independent predictor of the major thrombotic complications. So what do we have to cryoprecipitate? Not only the fibrinogen, however, they also include the factor 8, von Willebrand factor, factor 13. So as you know, von Willebrand factor has activated the factor 10 and the aggregate platelets. So as you can see that the liver failure has a rebalancing of the hemostasis. And then actually, to circumvent that, the hypocoagulability, and then the body create the more of the von Willebrand factor, and then decrease the enzyme Adams 13, which degrade the von Willebrand factor. So if you give the cryoprecipitate to increase the fibrinogen, and then, but at the same time, cryoprecipitate contain a significant number of the factor 8 and also von Willebrand factor, that may, tip the balance towards the thrombosis. That's the plausible concept. So there's a interest between the fibrinogen and concentrate without having those von Willebrand factor and a factor 8 and 13 versus cryoprecipitate to see what's the difference between those. Indeed, cardiac surgery, there's no inferiority study published recently. And then interestingly, there's no difference in the thrombotic complication. But again, this is the cardiac surgery. And so I hope to see that the similar study will be performed comparing the fibrinogen concentrate and the cryoprecipitate liver transplantation. And especially I'm interested in to see the complication rate of the thromboembolic events. So treatment of the PT during liver transplantation, and then so TPA, small dosage, 0.5 and 4 milligram makes so much difference. The first report is reported from Northwestern by the Dr. Andre De Wolf's team, 2011. So we applied the similar policy and prepare for the TPA for every single liver transplantation at the UPMC. And then the 2 vials of the TPA, 2 milligrams per vial in or each liver transplant cases, and then administer low dose if the PTE is diagnosed. And then transfer the unused TPA vials at room temperature for a couple of hours to go to the cardiology catheterization lab for the next day usage. So in such a way, none of the expensive medicine will be wasted. So among the 99 cases after the implementation of the policy, we identified the 45-year-old female developed the PTE. And then so, however, given that policy, we immediately inject the TPA 2 milligram IV within the 1 minute after the diagnosis. The thrombus is gone. And of course, TEG is become the flat, but 90 minutes after the, reperfusion time and also administration of the TPA, TEG is normalized, and then the surgical team can close the abdomen. The patient outcome is great. So, and then those low-dose TPA usage was reported and summarized again from the UCLA group. And then among the over 3,000 cases, they identified 11 thromboembolic complications. And then they provide TPA and then 100% clinical improvement and a 91% survival at 6 months. This is the huge, makes so much change with the TPA. So pulmonary thromboembolism during the liver transplantation is his significant problem. However, if you prepare yourself in the TPA, the small dosage, 0.5 to 4 milligram, that will make so much change in the outcome. So I just want to summarize the incidence of the intraoperative cardiac arrest in adult liver transplantation is significant. And then those risk factors were identified. And then one of the major reasons is the PTE, and then for which all the anesthesiologists have to prepare the TPA readily available. And then there's an implication of the cryoprecipitate may carry the risk of PTE. Thank you very much.
Thank you, Ted. It was a great presentation on some bad stuff that can happen during liver transplant. So before introducing the next speaker, let me just tell you that Dr. Sakai is also the past president of SATA, which co-sponsored this IARS meeting. Next speaker we have is Dr. Ryan Chadha, which is still part of the leadership of SATA, being one of the new elected counselor. Dr. Chadha is a good friend and associate professor of anesthesiologist and perioperative medicine at Mayo Clinic, Jacksonville, Florida. And today he's going to give us a presentation about if anybody can practice transplant anesthesia now and talk about the future of transplant anesthesiologists. Thank you, Ryan. It's all yours.
Can you guys hear me? Fantastic. Good. Perfect. I'm going to share my screen. And I'm going to, I got to switch this. Oop, oh, what did I just do? No. Oh, I locked. Of course. Give me 1 second, team. All right, you guys, I'm back. Sorry about that. I just locked my workstation. Let me move this. And you see my notes right now, right, Lorenzo? Which view do you see? Okay, so let me switch it.
Yeah, we see in your notes, the presentation mode.
Is this correct now?
Perfect. Yeah.
So I want to actually give a little story before I start. So first of all, thank you for the kind introduction, and thank you to the IARS for being invited. So my introduction to liver transplant was actually in 2014 when a certain doctor on this panel, Dr. Sakai, came to Yale, where I did my residency, and gave a resident lecture in Grand Rounds on liver transplantation, and he gave us a lecture on venous bypass. I really had no idea what he was talking about, but I was so amazed with the case that I kind of, at that point, committed that I kind of wanted to do liver transplants with my career. And I remember I went up to Ted, and I was Dr. Sakai, excuse me, at the time, and I just was saying, this is the coolest thing I've ever heard, and I definitely want to do this. And it is such an honor to be speaking now with him as part of a panel, and I totally feel completely underprepared, but I just wanted to give you that little story because that is what my first exposure to liver transplant. And it was funny because Dr. Gebhard Wagner, who was my mentor, was going to be the moderator. So again, just a truly wonderful experience. And thank you again for this opportunity. So I'm going to end. I'll try to keep this quick because I know we're behind on time. But today we're going to talk about, can anybody practice transplant anesthesia now, the future of transplant anesthesia. I have no disclosures. And I kind of do this slide quite a bit because, and I'm going to be focusing on deceased donor liver transplant. That's my practice. I don't do living donor at my center. So I'm going to just keep the topic there, but it still is applicable to the things I'm saying today are really applicable to all transplants. And I always like to say that, as you know, it's quite a journey for a patient to get a liver transplant. And they really have to go through a very long process from getting optimized and evaluated, getting listed, and getting transplanted. And then hopefully surviving long-term after the transplant. Now, we as anesthesiologists really focus on a really small element of this process. We really just focus on that immediate intraoperative, maybe slightly before, slightly after, but really that's kind of where our focus is. So we have always had a narrow viewpoint. And that narrow viewpoint kind of poses the question, do we make a difference? And I think that's been well-validated literature. As you guys know, the group in Mount Sinai really published the first paper that made the biggest difference, that showed that liver transplant providers that did less than 5 liver transplants were associated with an increased 30-day mortality. And these findings were repeated by the group at MUSC that found after they did 8 liver transplants, there was no difference in mortality than those versus those who did less than 8. So they kind of did the same study and kind of replicated from that. And so obviously there's a reason that we have liver transplant anesthesiologists. And these papers were from 2015 and 2021. And why is it? We know they make a difference. And the big reason is really Dr. Sakai really did a great job of kind of laying the foundation that we know that liver transplantation is not for the faint of heart. We really deal with the most intraoperative perturbations that you find outside of cardiothoracic surgery, in my opinion, as you can see here. So this is a record, one of my records that I've shown as a new attending, having a very nice severe hemodynamic instability there. This was one of my nice cases of a hyperkalemic arrest, as mentioned in the previous slide. Intracardiac thrombus after post-reperfusion syndrome, which we're going to touch upon, that happened to me as a second-year attending. This was a patient of RV dysfunction that I had about 5 years ago, a patient of LV dysfunction that happened a few months after that. So obviously, there's a reason why you need a specially trained group of liver transplant anesthesiologists, and a lot of it is based on the fact that over the last 20 years, critical event management is one of the key things. And one of the points is that we have taken it so seriously from the liver transplant anesthesiology community that we've actually come up with a statement saying that how do you manage, what are the most common causes of hemodynamic instability, and how often do they come? And you can see here, it kind of comes up such a large, different combination of things that can occur for why patients have hemodynamic instability intraoperatively in liver transplant, and they go from there. So, and you can see we have several other authors, including Dr. Wagner, on this paper from that end. And one of the big causes is post-reperfusion syndrome from that end. And that's why I want to draw your attention, because that's probably the biggest combined cause of why a liver transplant anesthesiologist in the last decade is trained to be able to manage post-reperfusion syndrome and its complications, because that is the highest reason for why we have critical events, as mentioned earlier in the OR from that perspective. And as shown in Dr. Sakai's study, the one common theme of all the incidences of intraoperative cardiac arrest were post-reperfusion syndrome, even in the most recent study that was published by Dr. Smith in 2022. Now, as you guys know, I'm not going to go through the definition of post-reperfusion syndrome, but both of these studies were out, both of these definitions, the earliest one and the most recent, were out of the UPMC group, and it was defined as a decrease in blood pressure less than 30% of the antipatic levels, and then was associated with other intraoperative perturbations, including arrhythmias and possibly coagulopathy. Now, the big thing we want to avoid, and I'm not going to spend too much time on this because Dr. Sakai reviewed those studies, is intraoperative cardiac arrest. And that's kind of what we're trained for in liver transplant anesthesia. And this study, which he already reviewed, again, I'm not going to go over that, but it did show that the biggest cause was post-reperfusion syndrome. So liver transplant anesthesiologists in their purest form are trained to manage critical events to avoid post-reperfusion syndrome, which is a common cause of intraoperative cardiac arrest. Oh, sorry for the repeat slide there. Ooh. And again, these studies were reviewed by Dr. Sakai, so I'm going to skip them. But again, they showed similar incidents, post-reperfusion syndrome being the common cause of intraoperative cardiac arrest from that end. I don't know why these are repeating. I apologize. But let's talk about machine perfusion, like Dr. Marchi talked about. Machine perfusion has been such an introduction, such a change in how we manage intraoperatively these patients. And there's a couple of different types of machine perfusion devices, as you know. There's the hypothermic, the transmedics, which the normothermic, which most of you are probably used to, as most of you centers possibly do that. Then we have the hypothermic and the bridge to life device, as seen there and seen. Those are kind of the most common devices. And what was the biggest thing that machine perfusion has done for us? Now, I have a talk that talks about 20, 30 studies on machine perfusion and why it's so good for the liver transplant anesthesiologist. I'm really going to talk to the big landmark study that came out in 2018 that was published by Dr. Nasrallah, a UK surgeon who studied quite a bit in normothermic machine perfusion and really talked about this. And what was the big thing in this study was he was looking at liver function, right? But the small piece that was really glossed over and picked up by the anesthesiologist like myself in this study was, if you look at the incidence of post-reperfusion syndrome, was greatly reduced in the patients that had normothermic machine perfusion versus those that had standard cold storage with SCS. So let's take a step back. The liver transplant anesthesiologist trains to avoid critical events most likely precipitated by post-reperfusion syndrome. We have found a therapy that potentially avoids post-reperfusion syndrome. So then that goes back to our first question. Do you really need, since there's no more PRS potentially, is there no more need for liver transplant anesthesia? And some people might argue, well, if they become safer intraoperatively, you really don't need them, right? Now, I actually argue that point, and that's what I'm going to kind of end the presentation talking about, that I think it's a redefinition of our role as we move forward. We've really been so focused on the intraoperative phase of care, and what we have to do realistically is we have to expand the way we think. We have to broaden what we contribute to the preoperative, to the whole perioperative process, and we go from there. Oh, my slides are a little bit out of order. I'm going to pause for 1 second. I apologize here. Okay, I think this slide was deleted, so I'm going to move forward. For some reason, I don't know what happened to my slides there, so I apologize. The previous slide I'm going to talk about was the recent publication that came out in 2023 by the AHA that talked about the workup of the lung, the liver, for coronary heart disease. And one of the big things that was shown in that publication, that was actually mentioned in that publication, was that anesthesiologists need to be involved in the preoperative discussions of patients with coronary disease. Now, that is a publication from the American Heart Association. Very few societies put out publications that show that an anesthesiologist must be involved. So what I do say is that when that happens, that shows that we need to be involved in the preoperative evaluation of these patients. Now, with the, let me switch my slides around, sorry. The next thing that's happened with machine perfusion is we've had an increase in combined transplants. So what you've seen now is we're having a lot more heart liver transplants, combined heart surgery with liver transplants, and lung liver transplants. So people think that, well, now machine perfusion, the logistics are solved, and I actually disagree with that. We've actually opened up a whole new area that we are kind of unknown about. And now we're being asked to work with our cardiac anesthesia colleagues and try to figure out how to bridge completely opposing physiologic goals intraoperatively in the immediate perioperative period. Because those of you who know, those of you who do cardiac and livers know, quite often, much different blood pressure parameters, much different hematologic goals versus the liver transplant that is handled much more liberally and much different physiology in those patients from that perspective. So I think this is something else that now we really have to enhance our knowledge in this area because we're going to see an uptick in that. In addition, we're probably just going to have increasing transplants. So what do we need to do? We need to make sure our pipeline is really strong of liver transplant anesthesiologists who understand how to handle these cases. These are some of the publications that we've looked at this, including making sure that we have well-trained people in their residency and fellowships if they continue to do fellowships. We make sure that the liver transplant anesthesiologist has essential knowledge skills that this has been published by the ILTS statement, as you can see there. And then how do we make sure the liver transplant teams are built to survive long-term, not get burnt out from that perspective. The next thing that must be embraced is enhanced recovery. The one thing we're realizing in that with machine perfusion and improved surgical techniques, optimized patients, we're getting patients to go through this perioperative period more uneventfully. So survival is not enough anymore. Now we need to make sure that every aspect of the recovery, like we do in colorectal surgery, ENT surgery, cardiothoracic surgery, we're enhancing recovery. And as you know, there was a large consensus conference that was done in 2021 that discussed this, in which we had several questions about intraoperative management from that perspective. Intraoperative interventions are going to remain the cornerstone of liver transplant anesthesiology, but we have to look at those intraoperative interventions to show safety, but perioperative mortality benefit. And we need to make sure we use them in every case. One example is TEE. I'm going to say this here. Varices is not a contraindication of TEEs. That should not be utilized anymore. Similarly, this paper out of Mount Sinai solidifies that TEE not only should be used, but it has a mortality benefit. Because as this group showed, they showed that in the pre-TEE era, all intracardiac thrombosis were detected by intraoperative cardiac arrest, versus in the TE area, all 20 out of 25 were picked up before intraoperative cardiac arrest. And as Dr. Sakai mentioned, patients with intraoperative cardiac arrest are more likely to have an event, but if you can avoid the arrest, they're more likely to survive and intervene upon it earlier. So TEE, purely for the reasons of clot detection, is beneficial from that end. And finally, we still need to be there for intraoperative rescue. And we are, as we mentioned, we are trained for that purpose, right? So as you can see here, this was a case from last week that I had, an intracardiac thrombus that I had from last week. And this did not happen after posterior perfusion. This happened during the dissection, routine dissection. The case was going uneventfully, and the patient threw a large clot into their RV. And we were able to handle it because, again, we are experts in that area. And there's an element of luck involved as well. But we are experts in this area, and that's why we need liver transplant anesthesiologists who know how to manage this. If we say, well, there's no posterior perfusion syndrome, this is going to happen. This happened an hour into the dissection from that perspective. The next aspect of intraoperative rescue that we need to get slightly better at and get more knowledgeable is extracorporeal support. We need to make sure that we know how to integrate that into liver transplant procedures now, because we're using it in combined heart, liver, lung, liver cases as well for rescue. ECMO is becoming, in the post-COVID era, a more standard of care therapy for management of hypoxemic respiratory failure, as well as end-stage cardiac conditions, as well as our transient cardiac conditions that we deal with liver transplant. So we need to learn how we use it as A, a bridge to transplant, and B, as a means to rescue. In addition, there's so many other devices that are coming in for bridge to transplant, as you can see on the cardiac side. Temporary support, Impella balloon pumps, mitral clips, things like that nature. We have to get a better understanding of that now as a liver transplant anesthesiologist. So the question is, though, do these procedures actually improve outcomes? And that's the big question, right? Because we know that these patients get long-term survival from these things, but as a bridge to transplant, is it appropriate to do a mitral clip, to do a TAVR? That's to be seen in the research. So I know I'm almost out of time. I know I overwent a little bit, but I want to say that liver transplant anesthesiology has long been defined by intraoperative critical event management, usually due to posterior perfusion syndrome. I think machine perfusion has hopefully reduced the incidence of perioperative events because it's solved posterior perfusion syndrome in a sense. And I think over the next 5 to 10 years, we'll see that. We will still be the experts in intraoperative critical event management. That is why we are there. But we need to expand what we do. We need a consistent presence of preoperative assessment, especially in coronary artery disease and combined surgery organ transplants. We need to make sure we maintain a competent FASA workforce. We need to look at every intervention we do, like TE, and make sure we're using it every case if it does have mortality benefit. And then we really need to make sure that we are adapting all of these modern rescue interventions and applying them to all cases. So with that, I'll end the talk. And again, thank you so much for the opportunity.
Thank you, Ryan. That was great. And just to piggyback what you said, another benefits of the utilization of machine perfusion is the fact, like I was mentioning before, improving the workflow that we have in the OR, and it's also a possibility for us anesthesiologists of becoming a leader in the operating room, because if you work in a place like mine, in which we decided to dedicate a room to transplant due to the increasing number of volume, and we assume the role or kind of the in charge, like a cardiac surgery model. We become the in charge person of the operating room. So definitely there's another benefit of that. We become a new level of leadership in the operating room in which we can be involved. Now, looking at the time, interest of time, we have not much, but I can see. So there were a couple of questions already kind of answered by Dr. Sakai. I'm going to start from the first one that hasn't been answered. That says, can cardiac anesthesiologists do liver transplant? Should a liver heart transplant anesthesiologist be a cardiac one, or liver transplant 1 or 2 attendings? Who wants to pick up this one? I've never done a liver heart, but I can say that for sure, for experience, I know that cardiac anesthesiologists used to do also liver transplant. That's probably, especially in programs at the beginning of their era, are leaning on cardiac anesthesiologists to start forming the transplant team. Now, there are not many centers that do heart and livers. And to my knowledge, there is a fair of the field, in the sense that the cardiac anesthesiologist takes care of the heart transplant or lung transplant sometimes, while the liver anesthesiology, comes in when there is the liver. But maybe somebody else is more knowledgeable than me.
Same experience, Lorenzo. And then in the UPMC, the initial part is the thoracic organ transplantation done by the cardiac anesthesiologist. And then moving on to the liver, and then so liver transplant anesthesiologists take over. And then so those are the two specialty combined cases treated that way.
I'm going to give my thoughts on this. I think we obviously we want to. There's a practical aspect of it. You want to use one anesthesiologist if you can. I do think that these cases, obviously for their individual parts, work well. It's fine to have the singular anesthesiologist involved. However, I do think when both organs are reperfused, there's a lot of unpredictability in two areas, both cardiac function based on vasoplegia, which I think it's good to have both individuals involved. Although I know the cardiac anesthesiologists are experts on that, so I don't want to speed that. But coagulation management is also really difficult in these patients. And like I said, because you typically have different competing interests as you have, and the liver physiology of a patient is so different. So I am a firm believer that even though you may have one, they should still co-manage the case throughout. You should have a dedicated. So what we do at our centers, we flip-flop anesthesiologists, but we keep someone committed to that room for the liver team or the cardiothoracic team, because it's just so unknown how these cases are going to go. Liver's not working in the setting of lungs working. Lungs are not working inside lungs. Cabbage is going to come off not functioning well, et cetera, et cetera. You want to be able to support each other from both ends. I think that would be my opinion. Is I think it's always best, especially if you're starting out, to have both groups involved, because I think you have a lot to learn from each other. And I've learned a lot from my cardiac colleagues, and I know they know much more than me, but occasionally I can give them a pearl or two about how the patient's doing from the liver standpoint and coagulation management. And I think that's the one thing they've heard, like, oh, wow, we have to be a lot more aggressive about volume, a lot more than we typically would be in a cardiac case, right? And balancing those things out, and then early initiation of ECMO that we might not be thinking about because we're giving so much volume. So I would say that I think these cases, they should be, especially if you haven't done them, start conservatively. That's my personal opinion. And then once you kind of develop your processes and protocols, and it's just the other difficulty too, these patients are so variable in how they are. Some of them are much more sick on the cardiac side. Some of them are much more sick on the liver side, right? But their heart is not strong enough to get them through a heart liver, right? So that would just be my only thought. It's just kind of always commit more resource. When you're giving two organs to a patient, I think it's not a big deal to ask for two anesthesiologists involved, in my opinion. So
I agree. So there were a couple of other questions. I'm just going to go briefly over it, just because they're related to one already. Dr. Sakai answered was, does a preoperative diagnosis of atrial fibrillation have a significant impact on intracardiac arrest? And the answer from Dr. Sakai was prevalence of pre-existing AFib for liver transplant recipient is around 5-7%. However, the condition did not turn out to be a risk factor in the study. So apparently, no. So the other question was, if we do intraoperative regardless of vagal varices status, Dr. Sakai gives his answer. Only the patient who received recent bending, less than 30 days, underwent the insertion. Among 1,200 cases of UPNC, there were only 2 GI bleed requiring EGD. Now, my intake is yes, in the sense that most of these patients come prepared, already bent, in 20 years, and the benefit, like you probably saw from many of the presentation that you had, are unimaginable. Okay, instead of looking at number on the screen, you can actually see what's going on and take consequently action. Therefore, in 20 years of my career, I haven't not put in a TE in only one transplant patient, which unfortunately bled 3 days before the transplant. But I still had the TE machine in my room, because in case of massive disaster, benefit and risk at that point would have been, boring me to put it in. But that's my personal experience, and the safety of that is documented by many articles nowadays, including the one that Dr. Chadha presented that was done by SATA people, including myself. And I don't know if you guys want to add something on this one.
So I can add, Dr. Sakai, can I make a few comments?
So
It was
go ahead, Ted. You go ahead.
Last one, right? Is there any association between the increased usage of the PCC, like Cassandra, in lieu of the plasma and the incidence of the intracardiac thrombosis? And so answer is that unknown. Most likely in the European center is try to use the component therapy compared to the United States. It would be interesting to see that result. But given the lack of the number of the PCC usage for the liver transplantation nowadays, even in the nowadays in the United States, we do not have the particular answer to that.
So I'll just make one comment to go back to the TE
Sure.
discussion, because there's another question about basic TE. And I'll just recency bias. My chair likes to bring up recency bias. I don't like to bring up recent cases, but I'll tell you about my last week. So last Sunday, I did a liver transplant in which I, due to significant coagulopathy, the TE must have caused some oral pharyngeal trauma, so a large amount of clots and stuff in the mouth. So that was in my head. This last case I showed you, the echo images I showed you, was a 40-year-old female, completely normal heart, slightly high meld, and had a stricture that they were able to pass a scope through, but they said it was tight. So I was like, you know what? I'm going to skip TE. Fast forward to the dissection. I get a spike in my PA pressures, spike in CVP. I put the TE in. So I think I am a firm believer that a TE for clot monitoring should be on every patient. I think, and I've always did that. And I think that is the one reason why. And that Mount Sinai paper verifies it. The TE protects you from intraoperative cardiac arrest because you pick it up sooner. So I think that you don't need the training. Now, again, that opens up a can of worms, right? Because do people feel comfortable putting the scope in, billing, the cost? There's a lot of things there. So I don't want to get down that. But I would say you don't need to be TE certified to do a 4-chamber review for clot monitoring. That's my personal opinion. I'm not TE certified. I never went through the testing, but I still place a TE routinely in all cases from that end. So that's my personal opinion. So
I totally agree. Especially, we know that TPA in small dosage is life-saving for those incidents. But before you commit for the TPA and then convince the surgeon, I'm going to give the TPA, we have to have the definitive diagnosis. And so the TEE is quite important to reach that diagnosis. And also timing itself is important. And so you can capture that, intracardiac thrombosis, and then you can make the snap diagnosis. And then so before the hemodynamic derangement. So, the seconds matter. So that's the reason the preparedness of the TPA and also the utilization of the TEE makes such difference. So, sometimes you have the back on TEE policy where you only insert the TEE after the hemodynamic derangement. Probably when you prepare everything, so thing is just go south too far, and then you may have the very difficult time to resuscitate the patient. So we are aware that there's a potential of the bleeding, which is actually the minimum. So benefit again for the insertion of the TE for almost every adult liver transplant patient makes sense to me personally, and which is demonstrated.
Yeah. And if I can piggyback on this one too, as I mentioned, yes, if you have any uh, problem because you think there is a risk, you can always, use a lago lubricant, put down the probe, take a quick look. If everything is okay, minimize the manipulation. If you have the luck, like I have, to have a pediatric probe, that can even help in using it much less traumatic. But I agree with Ted that waiting for the disaster to happen to put down a probe can actually translate in a bigger disaster. Because, for example, in my hospital, the surgeon used a stever retractor, which is basically a metal bar over the face of the patient. And inserting a TE is not always super easy, and you need to be very careful. So I can see myself in a situation of strong hemodynamic instability, try to put down the probe in somebody, which is difficult to do with a bar on the face, the risk to provoke more damage than benefits at the end. So, and I agree with Ryan, you don't need a certification to have a look and see, and put up a 4-chamber view, which you definitely need to convince surgeon or very practical animals, so they're not going to go after your explanation about the PA pressure, CVP, and tidal CO2. They just need one image to show the clot and a big right heart and tell them, if I cannot do TPA in this patient, you're going to lose it, and they're going to let you do that in a very bloody case. Anyway, I don't think there is any more question. I want to thanks again IARS for hosting and co-hosting with SATA this fantastic webinar, and for Dr. Sakai and Dr. Chadha for participating. And don't forget to look on the IARS website to follow up on the next webinar in January and February. Thank you very much, and have a good night, everyone.
Good night.
Bye, Ted.
Thank
Bye,
you.
Ryan.
Bye-bye.
Thanks, guys.